My dear students, in this video, I'm going to give you an update on some of the major changes in the stroke guidelines of AHA 2026. We all know that the previous guidelines were framed in 2018 with an update on 2019, and it has been quite some time. This guidelines required a revisit, and after this revisit, it has been reset. And in the context of this, I'm going you to highlight only the major changes that has been made as per these guidelines. The first point that needs discussion is the scope of treatment options, because the AHA guidelines in 2026 have expanded the stroke treatment options, and the new guidelines broadens which adults are eligible for advanced stroke therapies like endovascular therapy and thrombolytic drugs. Tenecteplase is now recommended as an alternative to alteplase for IV thrombolysis within the 4.5 hours window after symptom onset. And more to that, there is support for extended thrombolysis up to 9 hours in select cases using advanced imaging criteria like perfusion mismatch. Now let us see them one by one. First, I'm coming to the point of tenecteplase, which has been promoted in the ladder in order of its importance, and it is now formally endorsed as a preferred or equivalent alternative to alteplase. If we see the differences in these two drugs from the clinical context is that the alteplase, the dose is 0.9 milligrams per kg up to a maximum of 90, in contrast to tenecteplase, which is 0.25 mg per kg up to a maximum of 25 mg. The administration of alteplase requires an initial 10% bolus followed by 1 hour infusion of the remaining dose. Tenecteplase, only a single IV bolus suffices. The door to needle is slower with alteplase, faster with tenecteplase, and the costs and logistics have higher complexity for alteplase, which is comparatively simpler and cheaper with tenecteplase. So this promotion will have some major advantages in that it is possible for faster administration in ED and mobile stroke units. It can cause better recanalization before endovascular therapy, particularly in large vessel occlusion. And because by avoiding the infusion, there are lesser chances of nursing or infusion errors. Coming next to the extended IV thrombolysis window beyond 4.5 hours, so that rigid 4.5 hour rule of the previous guideline has been relaxed. And now the guidelines allow up to 9 hours or wake up stroke if advanced imaging shows perfusion diffusion mismatch or diffuse weighted imaging flare mismatch on MRI. And this recommendation in the guidelines is based on the reports of trials like Extend Wake Up and the Epithet, which all showed benefit with an extension of the thrombolysis window. So the clinical implication of the guidelines would be that a patient arriving at 7 hours is no longer automatically excluded if he has a small infarct core or a large penumbra, because in both cases it is possible to save the remaining part of the brain. Coming next to the endovascular thrombectomy, here the time window has also been expanded from 6 hours to 24 hours, and EVT is now standard in 6 to 24 hours from the last known well-being if imaging shows a small core infarct and a salvageable penumbra. There has also been a broadening of the eligibility criteria. Previously, the criteria was strict, that mandated an NIHSS score of greater than equal to 6 and only for ICA or proximal M1 vessels. But now the criteria has been made more flexible. Even endovascular thrombectomy can be done in lower NIHSS, that is even in 2 to 5 scores if it is disabling. In cases of distal occlusions also like M2 or M3 in select cases, and it has been formally endorsed for posterior circulation or basilar artery stroke as well. Third important point is also that the imaging-based selection replaces the time-based occlusion for EVT. The CT perfusion or MRI is now central, and the key matrices that require consideration are infarct core volume with a cerebral blood flow less than 30%, penumbra with a Tmax of more than 6 seconds, and a mismatch ratio greater than equal to 1.8, which allows even late presenters, wake up strokes, and unknown onset strokes to come under the purview of endovascular thrombectomy. There has also been some other modifications like bridging therapy, combining intravenous thrombolysis with endovascular therapy. This 2026 guidelines reaffirms this bridging therapy, and one should give IV thrombolysis before thrombectomy wherever it is not contraindicated. In posterior circulation stroke, this has been an area which has received a lot of attention in these guidelines. There has been a major upgrade because basilar artery occlusion is now one class 1 recommendation for EVT, and even up to 24 hours it can be considered if there is salvageable tissue. In mild but disabling stroke, it has got a new emphasis, that is patients with low NIHSS, that is in the score of 2 to 4, but with disabling symptoms like aphasia, hemianopia, dominant hand weakness, they should receive IVT with or without endovascular therapy. The guidelines also focused on special populations, including elderly, and no upper age limit has been fixed for IVT or EVT. Pre-stroke disability, that is a modified ranking scale of 2 to 3 patients, still eligible if meaningful recovery can be expected. And one important point which is unique to these guidelines is pediatric stroke, that is select adolescents may receive either IV thrombolysis or endovascular therapy in experienced centers. Coming to an important point is the pre-hospital and the EMS care enhancements which have been formulated in these guidelines. The guidelines endorse use of mobile stroke units or MSUs, which are ambulances with onboard CT scanners and trained personnel to begin diagnosis and start early treatment. There has been a focus on refined EMS triage protocols to help identify where patients should be taken first. That is, whether it should be an EVT capable center or it can be the nearest hospital. So this has to be decided based on certain characteristics. Now, standard pre-hospital stroke screening, as per the guidelines of 2026, focuses on two-tier stroke identification, and the EMS is now advised to use the tier 1 for general stroke recognition by using the FAST, BFAST, or the Cincinnati Pre-Hospital Stroke Scale, and in the tier 2 to predict large vessel occlusion, to detect thrombectomy eligible stroke by using RACE, LAMS, FAST ED, or CPSSS. So in those cases, direct transport to EVT capable centers should be done if there is high large vessel occlusion probability on pre-hospital scale, and if there is an additional transport time which is less than equal to 30 to 45 minutes. So in that case, the EMS can bypass the primary center and shift the patient directly to the EVT hub. That is as per the guidelines. So regarding the MSUs or the mobile stroke units and the pre-hospital imaging, what it spells is about mobile stroke units, which should be an ambulance equipped with onboard CT scanner, point of care lab, teleneurology, thrombolysis capability. And these are class 2A recommendations, especially for urban systems with high stroke volume. For pre-hospital imaging and telestroke, the new elements which have been included in these guidelines are real-time CT image transmission, then pre-notification to the cath lab or the neurointervention suite, and early consent discussions with the patient itself in the ambulance. Regarding pre-hospital blood pressure, airway, and destination protocols, also there are specific recommendations and as per the guidelines. For pre-hospital blood pressure and airway, the guideline formalizes to avoid aggressive BP lowering unless the systolic blood pressure is more than 220 mmHg or before IV thrombolysis with a target of less than 185 by 110 mmHg, to give oxygen only if saturation drops below 94%, and to secure airway or to intubate only if GCS is low or airway is unsafe, and even when they use to avoid hyperventilation. The hospitals have been categorized according to their levels and capability. When it is acute stroke ready, it should have the capability of both CT and IV thrombolysis. Primary stroke center should have 24/7 IV thrombolysis. The thrombectomy capable centers should have facilities for daytime endovascular therapy, and the comprehensive centers should have 24/7 EVT facilities plus ICU plus backup neurosurgery. And the EMS protocols must be region specific and pre-approved. Regarding pre-hospital stroke alerts and data integration, also the recent guidelines make some recommendation because it puts new emphasis on automatic stroke alert from ambulance, and by sharing the data about the last known well-being of the patient, the NIHSS estimate, the large vessel occlusion score, and the medications, particularly about the use of direct oral anticoagulants. Now this allows the CT scanner is reserved, the thrombolytic is prepared, the angio suit gets activated, and all these things happen before the patient actually arrives to the center. Now this guidelines empowers the EMS with large vessel occlusion tools, direct EVT routing, mobile stroke units, and real-time teleimaging to make treatment decisions before reaching the hospital. Next, these guidelines are the first ever pediatric acute stroke guidance. And for the first time, specific recommendations are included for recognizing and managing pediatric ischemic stroke, acknowledging that children can also benefit from early diagnosis and select interventions. The pediatric specific red flags include, unlike adults, the children often present with seizures, especially in patients with children who are neonates. They present with headache and vomiting. They present with altered behavior, and they can present with hemiparesis after infection or dehydration. The pediatric stroke pathway and in the guidelines mandates that it is dedicated code pediatric stroke should be there. And the time limits, of course, are similar to adults. That is, the CT or the MRI should take less than equal to 60 minutes, thrombolysis decision less than equal to 4.5 hours, and the EVT less than equal to 24 hours in the select cases. The guidelines are also inclusive of supportive interventions because treatments for post-stroke complications like dysphagia, with example pharyngeal electrical stimulation or PES, these are now recognized as part of recovery care. And therefore, this new guidelines mandates swallowing screening for all stroke patients before oral intake, within 24 hours of admission, and use of bedside swallow test or formal speech therapist assessment. The patients should be mobilized within 24 to 48 hours only if they are hemodynamically stable, there are no evidences of raised ICP, and there is no evolving infarct. Also, the patients are subjected to intermittent pneumatic compression, early pharmacological DVT prophylaxis, and pressure injury risk scoring. Regarding updated imaging and treatment thresholds, also there is a broader and more flexible use of advanced imaging to determine eligibility for treatment beyond conventional time windows. The 4.5 hour rule is replaced by EVT is now allowed even up to 24 hours, if depending upon the scenario and the imaging rule. So the 0 to 4.5 hours, the imaging rule is NCCT only. Between 4.5 to 9 hours, it can be either CTP or MR perfusion. In case of wake-up stroke, the diffusion weight imaging and the flare mismatch. For unknown onset, it is the perfusion mismatch. So the parameter EVT, when it is allowed up to 24 hours, if the parameter core requirement is the parameter with the requirements are, that is, the core should have less than 70 ml, the mismatch ratio should be more than equal to 1.8, the large vessel occlusion, that is either ICA M1, M2 or basilar, and the clinical deficit should be disabling. Regarding system level and hospital workflow improvements also, the current guidelines have laid down certain important points, an emphasis on coordinated stroke systems of care from the emergency call to hospital discharge should be there seamlessly so that evidence-based treatments can be delivered rapidly and efficiently. So the old matrices like the door to needle, door to groin, etc. has been replaced with new matrices like call to needle, call to deperfusion, and symptom to recanalization. So instead of first visit to the ED followed by registration, followed by CT, followed by labs, then consent and decision, now CT is ordered while patient is en route to the hospital, thrombolytics prepared before arrival, consent is initiated in the ambulance, angiosuit is activated preemptively before the patient actually reaches the hospital, and all of this together cuts 30 to 60 minutes without any new technology. Using the same technology, one can actually buy time. So my take home message on account of these changes would be that this guidelines mandates that stroke treatment is now driven by brain viability, not by the clock. Single bolus tenecteplase simplifies and accelerates reperfusion. So that has been included. EVT now applies up to 24 hours and beyond in anterior circulation. The stroke clock starts in the ambulance and it is not the hospital. Pediatric stroke is now a time critical emergency. Aspiration, fever, glucose, raised glucose, that is altered glucose levels, delirium, immobility, and hypotension, they cause more disability, may cause more disability than the original infarct, and all of these have been included in the management, and all of these have been given the due importance in these guidelines. And finally, the imaging is and not the time defines when not to treat. Thank you.